is, are we realizing it to its full capacity, and where's the potential for increased use, and what are the barriers that are stopping us from doing that? So to start out with, just by way of some definitions, this is something that may be a trivial point, but there's a lot of terminology that's thrown out when we talk about electronic medical records. So electronic health record and electronic medical record is often used interchangeably, but it turns out they have slightly nuanced definitions. To begin with, electronic health record is more of a global concept. It refers to all of the electronic medical records from different vendors, from different providers. If you get your vaccinations in one state as a child and then you go to another place and you have most of your electronic records somewhere else, the global collection of information across multiple states and parties is the electronic health record. The electronic health records may include such information as your demographics, your medical history, immunization, all the way through pretty much everything that's relevant to your health that can be stored electronically. And this is something that we're all familiar with. I don't know what that background noise is. The electronic medical record is more of an individual vendor, so they tend to be part of a local standalone health information system that allows storage, retrieval, and modification of records. So EPIC is an example of an electronic medical record. A personal health record is generally defined as an EMR or an EHR that the individual patient controls. And this is something also that a lot of people may not understand. Is that me? What's that? Oh, okay. All right. Wouldn't be a presentation if there weren't technological glitches involved, so especially on a technology topic. So looking at how these things fit together, here's a little bit of a schematic. So all the white circles are electronic medical records. Obviously, there's dozens of different potential vendors that you can use. Personal health records, something that people are less familiar with. Google had one, and then they sort of abandoned it, and they're closing that down. Microsoft has one called Health Vault, and there are a number of others as well. Of course, we have our own institutional personal health record through MyChart that allows patients to access their own health information. But it's limited, and it's not controlled by the patient, at least not wholly. It's controlled by the provider and by the institution here. And so there's different sort of nuance in the way that these systems are used interchangeably and the terminology is used. So talking about the potential advantages, you may have noticed my introductory slide that had my title was handwritten. So that's supposed to be kind of a play on the fact that the most obvious advantage of this kind of electronic medical record is in the fact that the information is stored in a better format, and hopefully a more reliable and accessible format. But it's more than that. So often, you know, I watch PowerPoint presentations fairly frequently as a physician, as I'm doing continuing medical education, and there's some people who use very graphic intensive, they use visual aids for PowerPoint, and then there are some that just basically take their speech, the text, and put it up on the screen, and that's their version of kind of a visual aid or giving a presentation. You know, mine's somewhere in the middle. It's nothing special, but we're trying to get beyond the idea of just taking the paper chart and making it electronic. That's not really what we're trying to accomplish here. It's a much broader scope than that. And so where does it all fit in? I kind of designated my own 3 categories. This isn't from any paper or government bureau or anything like that, but I think of it in terms of administrative, patient care, and societal benefits that come from the electronic medical record. And each of these areas has their own list of advantages. So administratively, obviously, storage space is much larger. You don't need a closet. You can just get your information on the server and you can access that from anywhere. And multiple users can use it. You don't need to chase down charts, have people constantly, you still have to, why we have all these archive charts. You have to send clerks to the warehouse or wherever you're storing all of your old information. And that's especially true in radiation oncology, where it's very important if patients had previous radiation that we have the original records. But you have relatively quick access, and you don't have to worry about not being able to read the text. That's a big issue. That can't be emphasized enough. So patient care benefits, I think, is what most of us think of as the real underlying driver for electronic medical records. If we can improve the quality of our care, isn't that the most important thing? So we can decrease errors. This has been shown that this is real and this has happened. Cross-check medications, avoid duplicate orders, allergens, DNR, all these sorts of things. At the end here, I have facilitate quality with required stopping points like timeouts and checklists. Those sorts of things are not necessarily implemented as fully as they could be. Some places they are, some places they're not. And then there's kind of the more population or larger scale benefits. When we have all of our medical information about individual patients stored in a central repository, there's at least a theoretical benefit that we can access this information and do research in a way that gives us extraordinary statistical power so that we can answer questions that we can't currently answer. And that is going to be an enormous benefit of electronic medical records, although it's not currently really that refined. We can monitor trends in treatment. So, for example, in radiation oncology, intensity modulated radiation therapy is a very expensive, very fancy treatment that gets all the press. And for some things it's very valuable, and for other things it's not as valuable, but we find that you can watch and see how fee-for-service and utilization are all tied together as you monitor these things electronically. Right now we use surrogates. We use billing databases as surrogates for the actual treatments, and they're not as accurate. There may be errors prone in there, and so this is going to help with that and allow us to get a little bit more precise. So, which of these advantages are real as of right now, and which ones are still kind of imaginary? I think that everyone in this room uses electronic medical records, and so I think we have a baseline idea of which ones are real, but I'm going to walk through it a little bit. I think the answer lies in information technology. The more difficult the problem is in information technology, the less we have currently tapped into that potential. And so I'm going to get into this a little bit more, but here's a quote from David Blumenthal, who's the National Coordinator for Health Information Technology. He says, "Information is the lifeblood of medicine, and health information technology is destined to be the circulatory system for that information." So this is a little bit of a cliche, I suppose, but these are my two little boys. I have a 7-year-old boy and a 2-year-old boy, and this is them using my wife's iPad. And it turns out my 2-year-old is very facile. He can get exactly to where he wants to go. He can read his Thomas the Train books. He can watch Netflix cartoons. He can draw pictures. He knows how to use this device intuitively and immediately. It's not like I sat down and showed him how to do it. He's also broken our iPad, so that tells you something else. But it is currently repaired and functioning properly, and he uses that regularly. My 7-year-old also uses it regularly. And it turns out that information technology as a larger discipline outside of healthcare is just extraordinary. We have so many amazing products available, insanely great things, but how have these things really come over into healthcare? We're going to talk about that a little bit. And why is that important? Because at the root of healthcare delivery, it's about information. It's about teaching, and doctor, in fact, comes from the Latin for teach. And in order to teach, you need to have information available for that. So I'm going to take you through a little tour of history here. I was showing these slides to some folks in my department yesterday, and they pointed out you could go back and start with like cave drawings and go pen and quill and go to the Gutenberg printing press, and eventually now we have incredible information technology that allows desktop publishing and that sort of thing. This is kind of taking the text and putting it on the screen. It's a little bit of a low-level application of technology, even though it's incredible and it's revolutionized our lives. Next up is storage space. So Google has a project in which they're attempting to scan every single book that's ever been published in the world in any language and make that information indexed and accessible anywhere. What an extraordinary project. And of course there's a lot of challenges to that, both regulatory and privacy and antitrust and all sorts of problems that is coming to that. But here you have your library stacks, and in one of these micro SD cards you can have 64 gigabytes of information that will hold thousands of books. It's incredible. Moving forward in time a little bit, so now it's not just a matter of putting text on a screen, but this is an example of where we take information and not just digitize it, but add artificial intelligence and processing capability. You have software engineers that make the information more usable because of the way it's delivered. And so when you have GPS and mapping software, it's not just a matter of putting the map up on a screen and having the map available anywhere you are, although that's something. The fact that every single map in the United States is available to me in my car is incredible. But it's the fact that you can use that map to find the shortest route, and you can use that map to find the closest gas station, and to get around detours, and to avoid one-way roads, and all sorts of information that is built into the capabilities of the system. So we're moving in the right direction. As far as finding answers, it used to be maybe you had to climb a mountain to ask a guru, but now you can just type query in Google and get your answer in 3 seconds. and find something that may be even more satisfactory. And this, again, is the result of incredible engineering that happens behind the scenes. So I just finished, and actually I have a slide later, so I'm skipping ahead a little bit, but I just finished listening to an audiobook while I'm commuting to my outreach clinic in the Plex, which is a history of Google. And it talks about these technological advancements, incremental advances over the last 10 years. It's absolutely phenomenal. It's amazing. And Google in particular, you go to their homepage and there's a text box and a button. And it belies the fact that they have tens of thousands of engineers that are constantly refining the way that you get information on the internet so that you can find the most appropriate information as quickly as possible. So this is Wolfram Alpha. That's a different kind of search engine you may be less familiar with, but they have enormous tables of data, and they've tried to develop artificial intelligence that's able to use this data so that when you do a search, it provides you real-time answers to questions, not just referencing answers that are elsewhere on the internet. So you can type in a calculus equation, for example, and it will give you the answer, and it will give you a graph, and I mean, it's incredible the types of things that they've engineered into things on the internet these days. So now I'm going to give you a little flashback to the 80s.
Please. Computer? Computer? Hello, computer.
Just use the keyboard.
Keyboard. Oh, great.
All right, now let's fast forward to 2012.
I've got to get a guitar.
I found 12 musical instrument stores.
How do I play the London Call? Whole lot of love?
I'll be minor ninth.
I found this for you.
Add migraine headache to my list of band names. Tell Julie and Kate our band is playing at the garage tonight.
Here's your message to Julie and Kate.
Call me Rock God.
From now on, I'll call you Rock God, okay?
All right, so the future is now. We've gone from in the 80s where it was a joke to talk, you could talk to the computer, and they came from the 23rd century, and now it's part of, I've got one in my pocket. Half the people here probably use it every day, and it's kind of what we expect. And this information technology is pervasive in our lives, but is it in healthcare? So let's talk about that for a minute. So we've been able to take these enormous stacks of charts, paper charts, and put them onto the screen. Check that box. You're able to read handwriting more legibly. You're able to access information from different terminals and not have to lose the chart and not find past medical information. Checks for medications, it's like a spell check. As you put in your medication, it'll say there's a conflict here or this dose doesn't make sense. That's present. We're doing that. But what about this? If I type in a name on Google and I spell it wrong, it says, did you mean, and then it gives me an alternative spelling. If I do that in Epic, it says, there's nothing there. I'm sorry, that's it. End of query. And similarly, if I type in a name where there's dozens of results, why can't it come up and just tell me the one that it knows, because there's records there that I wrote that that's my patient? Why can't it give me sort of, those cues are what's built into Google, but not built into our electronic medical record. And so it's a little bit more nuanced, but it belies the complexity of how that's achieved, but it's not available right now in Epic. And what about this? You have a physician talking to a resident, asking to do a chart review, saying, I have a clinical question. I want you to go back and find the charts. I want you to answer this question. We're going to analyze the data. And wouldn't it be nice if we could do that in our EMR? If we could do a search, find all the patients that are applicable, do a little bit of analysis, and find the answer that we need immediately. I don't know where that's available. I don't think that is available. And it turns out, I just finished residency a few months ago, and during my residency, I did research projects on a regular basis, and we do the same chart pulling effort now, even though there should be much better information technology. And so it's like a conveyor belt that goes along where you pull all the charts, you mine the data, you spend hours reading through the charts, and then building a new database in an Excel spreadsheet that shows the specific stage of cancer and their specific clinical characteristics and pathologic characteristics and age and demographics. And then you do data analysis with a statistician, and as the conveyor belt goes along, you pile up more and more information that you're creating and generating and organizing, and ultimately you get a publication out of it, or at the very least an abstract, and new information that can help with medical care. And at the end of the conveyor belt is a trash bin. And all of this work goes into the trash bin because save for the summarized information that's in the manuscript itself, all of the data that you've collected and collated is no longer available to anyone else in the medical field. It's just gone. And it's not accessible to anyone else, and that's a serious problem with our current electronic medical records. So before I get onto this slide, I just want to point out the difference between the technological advances I showed prior to the little video clips and those in healthcare afterwards. We aren't taking advantage of all of the incredible information technology that there is available. And the question is, why is that? There are other barriers. It's not just the technology. It's also us. And I'm going to get to that eventually. But this is what I think is just fascinating. And so EMR development has been driven by a lot of different ideals. People have different ideas of why an EMR is useful. And so they come to the problem of solving the EMR issue from totally different areas. And I think public policy in a large part has guided this process. And so you get a little bit of a bias in the way that these products are designed and the goals that we're trying to achieve. And so I want to talk about that here. If it's industry guided, you might get a different answer than if it's government guided. So another one of my books, I've listened to more books in the last 6 months going to outreach clinic than probably in the previous 5 years of residency. And this is one of them, the Steve Jobs biography. He says it's really hard to design products by focus groups. A lot of times people don't know what they want until you show it to them. And I think that's true. How many of us knew how cool an iPhone would be until you pick one up and you're like, this is really cool. This is really helpful. This is something I will use a lot. And the question is, why isn't there Steve Jobs in medicine that's given us an EMR? We're like, this is going to solve so many problems. When you look at an iPhone, you have a home button, one button, and you have some icons, and you can swipe it back and forth. When you look at the Epic home screen, you've got 5,000 buttons and 47 tabs, and I still don't know how to. I just found out yesterday there's functionality that's been in there for months that I never even knew about, and where's the button for that? And the problem is that you have to have constant training and constant updating of information so that you can keep on top of how to use this stuff. So here's the book that I was talking about. In the Plex that talks about Google. These guys are brilliant. They're very data driven. They started Google with the idea that they're not going to just conform to the conventions of the day. As you know, Google data centers, where they hold all that information, they run those data centers hot, and they use the cheapest possible components for their servers, expecting that the hard drives will fail at like 20 to 30% rate. That's completely against industry standards, or at least has been for the last several years. Now it's probably more standard because Google's made it so successful. But they ask a question, what are we trying to accomplish, and what are the conventional assumptions of this, and which one of those are wrong, and how can we do it better and cheaper? And there's really smart people that are data driven. They're actually committed to one-upping each other. There's a little bit of competition inside the organization in terms of trying to get the data on your side, because you can't argue with data. You're entitled to your opinion, but you're not entitled to your own facts. And so that's something that came up over and over in this book. So this is my little fantasy. If I think about if Google actually created the EMR, what would it look like? And all the technologies I put on this slide, I'm going to describe to you, they exist. There's no reason this couldn't actually be applied, but they haven't been integrated. We don't have the engineering mass of people that are working on this problem successfully now to make this happen currently, or the infrastructure for sharing information because of the regulatory issues and that sort of thing. But here's what I can imagine the EMR being. The physician goes into the room with the patient. There's a computer in the room that has a microphone that listens into the discussion as the physician does the physical and the history. All of the information is recorded, and then the computer is able to distinguish the voice of the physician from that of the patient, from other family members who may be there and their questions, and record the information that's gathered not just into the electronic medical record, but into the structured parts of the medical record, updating the problem list, updating the allergies and the medications in the appropriate fields, not just in a narrative fashion. And that way afterwards the physician sits down at the computer, sees all of these things, approves that they're correct, sees the orders that have already been prepared for him in terms of new medications, new follow-up visits and consultations with other care providers and that sort of thing, and just says yes, and it's already put in, and then the physician doesn't feel like they're a data entry specialist that needs to spend another hour with the computer after they spend an hour with the patient. But alas, this is not real. This does not happen right now. It's much more than voice recognition software. As you know, it's fairly common, and there's capability that we have that will take speech and convert it to text, but That's analogous to taking a paper and putting it on the screen. It belies much more capability there that's not being utilized. Second of all, there's no search in EMR. It'd be wonderful if there were search, and I understand that there's a lot of problems with this in terms of privacy and regulatory issues and that sort of thing, but it seems that we have well-established technology that indexes large records, large mountains of information, and allow us to get to what we need more quickly. And I don't know why we don't have something like that in the electronic medical record. So if I can't remember the patient's name that I saw 6 months ago that was supposed to come for a follow-up, but I haven't seen them, it's going to be really hard for me to go back and dig that up manually, but that's what you have to do right now. So what we have is a policy-driven EMR. This is the graphic on the right is a diagram showing from a government paper that shows some of the interoperability standards as we try to have the different vendors work together to exchange information more capably. And to give you a little bit of background, historically, we all know this. I'm sure you've been to other talks where this has been covered, but HIPAA started back in 1996 with this act of Congress that then had Title II, known as the Administrative Simplification Provision, which is one of the most laughably euphemistic titles I could imagine because it's complicated everything and had so many extraordinary costs in it. But this is what kind of sets the stage for the challenges that we face right now. It's important to protect patient information. I believe that. This was intended to facilitate appropriate use of information and privacy, and I think it's thrown up a lot of roadblocks because it's very micromanaging in the way that we do that. Now, of course, this again, I don't know how many people recognize this, but it's certainly gotten a lot of play. If you've been to any medical grand rounds in the last 10 years, I'm sure you've heard of this at least part of the time, but there was a Institute of Medicine report that talked about medical errors that kill Americans. So, many more Americans die every year as a result of medical errors than die from tobacco, it turns out. And so they come to us for help, and because of our errors, we harm them. And we would like to believe that since 1999, we've been able to systematically change the way that we provide care, and we've been able to improve this, but it turns out, alas, that is not true. There's a number of recent reports that show that we haven't made nearly the progress that we would have liked to, although there have been marginal improvements, many of them due to the electronic medical record. But at the bottom here, you see the bullet point mentions the decentralized and fragmented nature of the healthcare delivery system as contributing to unsafe conditions. So it's part of the problem that there's sign-off from the time that the paramedics sign off to the emergency department, to the admitting physician, to the specialist, to all the way through here. You're waiting to do your documentation until 2 days later, and that. It's very fragmented, and there's challenges in terms of communication and information exchange, basically. So fast forward about a decade, and we have the stimulus package. So the American Recovery and Reinvestment Act of 2009, you all remember this, was passed, and as a part of that, we had the High-Tech Act. And the High-Tech Act stands for Health Information Technology for Economic and Clinical Health. And I've got a couple quotes here that very optimistically assess what the government is doing here with all of our taxpayer dollars and talk about how wonderful this is going to be. And the bottom line is we got $50 billion to throw at healthcare, and what are we going to do with that? How are we going to do it well? I indulge myself in being a little bit snarky on this slide. So there's a lot of money just waiting to be spent. There's a snappy acronym. It's high tech. Get it? High tech. We got to use that. We got to spend $50 billion to use that one. And so, unfortunately, what this means is that now the development of the electronic medical record is being dictated in large part by bureaucrats. It's not all bad, but I'm trying not to make this a political statement here, but I've seen what Steve Jobs and Google and these Silicon Valley types can do, and I've seen what the government can do, and they're not quite equivalent. And so I consider this to be part of the problem. So on balance, spending millions and millions of dollars for an electronic medical record is a high cost. And now the question remains, what are the benefits that we've been able to realize from that, and what influences those benefits? Well, it sweetens the deal a little bit if the government's willing to dump $50 billion on us and pay up to $44,000 per provider for what we will call sticks and carrots, meaningful use. So as long as we can get an electronic medical record that's going to allow us to really impact patient care, the government says, we will reward you for that, but it can't just be checking the box, putting the words on the screen. This has to translate into real care improvements. And how we're going to do that is, I'll skip that slide real quick. This is how we're going to do that. Meaningful use goals. Improve quality, safety, efficiency, and reduce disparities. So computerized order entry is going to help with that. Engage patients and families in their healthcare. We're going to give them an electronic copy and allow them access. That's going to help with that. Improve care coordination. Exchange key clinical information with other providers. So we constantly have the inbox flowing back and forth inside Epic and between institutions. So this is one of those things that I just learned yesterday, that we have the capability to actually import data on a patient from the University of Iowa, for example, into our Epic because they use the same vendor. That's been in place since March, apparently. That was before I worked here. So I missed the memo. I missed the announcement and wasn't aware that this even happened. And it turns out University of Iowa didn't have it at the same time we had it. And so after you all got the memo, it didn't work until they implemented it as well. And then it's not one of the 47 buttons on the Epic home screen. And so even if it's available, you don't know it's available unless you got the memo back in March and the update when University of Iowa got it, and you know how to find the button inside the system. And so there's still some challenges to reaching these goals for meaningful use, but we are getting there. I don't know what the plan is to actually import data from all scripts and some of the other electronic medical records, but at least for Epic to Epic, we now have something, and that's something. That means something, and it will help with redundant clerical work. Improve population and public health. So I mentioned that before, and we're talking about immunization registries. Ensure adequate privacy and security protections for personal health information, and that just goes without saying. That's important when we have an electronic medical record. The meaningful use timeline, we're in the middle of the first part right now, and we all know this. I mean, I imagine there are people here who have heard this ad nauseum and are sick of hearing about meaningful use, but those people probably avoided my presentation altogether. So I'm assuming that the people who are here are interested in meaningful use, and it turns out the stage 2 guidelines were recently published, like 1 week ago, back February 22nd. They just barely came out. Now they're available for comment, and they're published in the Federal Register or something like that. And you know, different organizations, the American Medical Association and others, are now reviewing those. This interoperability between different vendors and being able to import information back and forth is a key part of that. And so you're going to see more and more advanced usage of the electronic medical record as you go through. So the timeline is from 2011, then 2013 is stage 2, and 2015 is stage 3. And hopefully by the time we finish, we will demonstrate improved outcomes, and we'll know that throwing all this money at this is actually doing the good that we all believe that it should be doing. And indeed, we know that it is doing, at least in part, with decreasing medication errors and that sort of thing. So I think we've really made some progress. We've really counteracted the millions of dollars that we invested, the time that we've invested, the frustrations and headaches that we've invested in bringing this forward and improving patient care. Many of those things on that meaningful use slide, as far as allowing patients access to their information through my chart, those things are happening. And they may not be a perfect system, and there may be a small percentage of patients who are adopting that right now, but it's moving forward. And so we're really equalizing things, and we're starting to see some of the benefits. But unfortunately, there's two sides to every coin, and for all of the benefits there's some drawbacks. And some of those things don't get a lot of press time, and I want to be realistic about this, so I'm going to talk about that briefly. So along with the administrative benefits, there's these drawbacks: server downtime, slow software. I find that when I'm running back and forth, I have 1 day a week when I see all of my patients who are undergoing radiation, and depending on the schedule, I may have the whole hallway lined up with patients waiting to see me. And for me to walk in the room, log in, pull up the record, pull up that patient's record, find this record, put in this information, type it all out, is not practical. So you find, and I don't know, but I imagine there may be some nurses here who have been guilty of writing down vital signs on a sticky note and then putting it in the computer later, and that sort of thing, because it just takes so doggone long to log in and go from room to room and that sort of thing. So these are the cons associated with it. There's a paper chart. You carry the thing from one room to the next, and there's no boot up time. The paper chart doesn't require a hard boot, so you can do that. Now, this is kind of a cynical assessment. EMR stands for efficiency mauled repeatedly. And so this physician is an oncologist, and he says, we basically become highly paid data entry specialists. And he echoes the sentiment I said earlier, where you spend an hour with the patient, then you spend an hour or maybe even more with the computer immediately afterwards to go through all of this and put in the structured data and that sort of a thing. Well, part of that's a learning curve, and it may be an unfair assessment, but I think that accurately reflects many physicians and care providers' objections and difficulties with the electronic medical record. So I don't want to dismiss that. I don't want to be dismissive, because I think it's legitimate that there is extra effort involved in learning these new things. Decreasing costs. So when I was getting some feedback on this presentation, it was mentioned to me, we didn't think it was going to cost less. We knew that this was going to be a cost, but it would be offset a little bit by some benefits here or there. But the real bottom line is patient benefits, so it's worth the cost. But I looked back through the internet at some of the published things from the government and different companies, and decreasing costs is a big selling point. It's something that a lot of people emphasize, that this is going to actually control the delivery costs of healthcare, and it turns out that's not necessarily true. As we know, it's a mixed bag at best, but a lot of the people, in fact, a third of the people who are looking for electronic medical records these days are already have an existing electronic medical record, and they're trying to find a replacement. Now, part of that's because of the meaningful use thing, and there's all that money waiting to be had, and so they have to fulfill those criteria and check those boxes, and so they need a new vendor. But in general, it's going to be an ongoing investment indefinitely. It's not something you pay once and then you're done with it. And you're at the mercy of the particular vendor you choose. If they have great implementation of new technology, fantastic. But once you're their customer, there might be a little bit of an incentive, less of an incentive for them to continue to develop their product on a quality basis. Reducing medical errors. How much does Epic cost? And that's, as I mentioned, this was about patient safety and not cost. But how much are we successful at reducing medical errors? I would say that it's mixed data. I think that overwhelmingly most people are under the impression that we have reduced medical errors, and indeed there's many published reports that show that particularly with medication administration and order processing, we have reduced errors, and we've increased patient safety and improved outcomes. However, there's ostensibly a whole other category of decreasing these medical errors from that Institute of Medicine report that has not been realized. And indeed, in this case, a pediatric intensive care unit in Pittsburgh saw a significant increase in mortality after adopting a new computerized physician order entry system. And this is encapsulated in another Institute of Medicine report that's more recent that talks about health IT and patient safety. And it points out that we've been going full hog into this patient IT thing, and there haven't been a whole lot of people who have been as cautious as they need to be in saying, look, if we establish this, we're going to delay the patient. For example, in Pittsburgh, some of the issues were when patients were en route, they couldn't sign their orders. They had to wait until the patient was admitted or present personally before they could actually do their order sets. So when the patient got there, there was a delay in care. And that may be one of the things that contributed to the increased mortality. There were other places where this pharmacy wasn't compatible with electronic medical records, so they were going to another pharmacy further away. And there's a full bulleted list in this report that shows how some of these things have been implemented poorly. So it's hard to know if you can really put that on the EMR or not, but one way or another, we have to take responsibility for the fact that we may not getting all the benefits that we would like to at this point. So supporting evidence-based decision support and outcomes. So this is the pie in the sky part. This is the part where I believe that we have an incredible ability to have live evaluation of new treatments and to find trends while they're in their infancy, instead of waiting for 10 years and 20 years of follow-up to be able to compare a treatment to the historical controls. That kind of technology and power is available when you have hundreds of millions of records to use for the number crunching. And you have a resolution of data that allows you to control for confounders. But that is not available presently, and I'm going to get into why. So the EMR has, on balance, provided some real benefits. It has definitely presented some real costs. I think that the most benefits will come once we finally can tap the information technology, as I've talked about before, to get some features that are not currently available, and that's what's really going to get us on the benefit side. The other thing that you need to keep in mind is the balance sheet. And this is something that, I don't know how much I believe this, but I've heard it talked about, and so I just bring it up here. These are the three categories I came up with, but if you throw on there who's paying for those benefits and who's receiving the economic, at least, benefits back again, or the care benefits, it ends up being us, the institution, and the physicians who are paving the way to use the electronic medical record, but societies and insurance companies and a lot of third parties are the ones who are reaping the rewards of that. And that sort of disjointed nature of this makes for some contradictory incentives. So if we're going to get the benefits back to the favorable side of the balance here, if we're paying all the costs, we need to keep in mind the real costs. The real costs are not so much the financial ones, or at least those are real costs as well, but the more significant costs, in my view, are the cost in time and effort. And so specifically, interacting with the computer is more than just dictating. It's more than just saying your SOAP note or your history and physical. It's putting it into the appropriate part, taking previous records, the problem list or the medication list, and updating those, and discontinuing medications that are actually discontinued, and updating the allergies. Those are things that take a lot more effort than just reading it into a microphone. And one reason why is because free text narrative, well, actually, let me go back a little bit. List tables codes are ideal for data analysis. We don't yet have the information technology that's able to go in and mine out all of this information and then do the analysis that we need, unless it's in a structured format, so that the stage of the cancer is in a field by itself, and this symptom is in a field by itself. But when you talk about the point-and-click boilerplate, if you start putting them in fields, you're going to lose resolution of information. You're going to have sort of a watering down of the nuanced details of a patient's clinical history that are important for care. And so it's a mixed bag, but ultimately we need to find a way to compromise and put both of those into play. All right, so here's the middle part of the talk, where I've been trying to decide how much of this to include, because it's the more data part of the talk. It's actually research part, and that seems more in line with conventional grand rounds. But I think it's a little more boring. So I'm probably just, and also I'm pushing the time a little bit. So I'm going to go a little bit fast over this. But the principle of garbage in, garbage out is one that I looked into as a medical resident. Specifically, we have an electronic medical record in radiation oncology that tracks patient treatments. It turns out when you have a specialty that's as small as radiation oncology and has esoteric enough information, there's no field for that in the electronic medical record of Epic or Allscripts or something like that. You need a specialized electronic medical record, and then that introduces a whole nother constellation of problems that you can have to deal with. But it's something that at least has been in place for many years in radiation oncology and allows us to do some analysis on electronic records and what we can do with that. So basically what I did, and I'm just going to buzz through this because it's boring, but basically I worked with a company called Elekta. They're one of the large vendors in radiation oncology, and they developed a little program, a DLL, that's installed in their institutions that use their software. And it would take the specific patient information, and this is totally destroyed formatting when I switched it over apparently, but take the patient information, make it anonymous, so take out all the personally identifiable information and collate it into a database. Upload that database along with other regional centers into a common registry. So RODA stands for Radiation Oncology Data Alliance, and it's a database that's kept by Elekta itself. And this is done on a regular basis each month on an unattended basis. All of the medical records are being uploaded to a common place after the personally identifiable information is stripped out. And so now you have a database where you can do some analysis. You can really get into the high-powered statistical epidemiological studies that I was talking about. So how well does this work? Here's some more fluffy slides that show you. So here's the problem. Variable list. This is the information that's included in this EMR. The problem is this information was also included in their institution's main electronic medical record, so their Epic or Eclipsis or Allscripts or whatever it was for their institution. Now when you have redundant places to keep information, people get tired of putting it in twice, and so people would routinely ignore putting it into the second record, and so there was incomplete information, and so you had a lot of blank fields in the structured database for this particular product. So bottom line, we did this, we found that it worked, we found that you got great access to data, the unattended uploads worked fantastically, you could do analysis afterwards. The results were considered to be a success. We thought that this is something that can be used for comparative effectiveness research. This is something that we can get other vendors to be involved with, and we can really pioneer this idea of having regional information exchanges where we can do this analysis. But it turns out my follow-up poster was a little bit less optimistic. This is a poster I presented at a professional meeting. And basically when we started drilling down and looking at it, there was a lot of stuff in this record that just seemed wrong. That just seemed like this is not right, this is an error, or it's incomplete. Or you have a diagnosis that says right breast cancer, and right breast cancer is in that field. You can write out the words right breast cancer either by abbreviating right several ways, or abbreviating breast several ways, or using substitution pathology instead of cancer, say carcinoma, or ductal, or lobular, or whatever. There's hundreds of ways to write that one diagnosis, and they were not necessarily all being combined, and couldn't be intelligently combined without human intervention. And so then you're back to the idea of a lot of data entry and overhead in terms of that. And so it was a little bit disappointing, but that's where we're at. We're back to the principle of garbage in, garbage out. Oops, I'm the wrong button. So in this case, it became clear to me that it wasn't garbage per se, but there were errors and there were biases in the database and in the information registry that could not be discovered. We could not be sure of the quality of the data without a lot of extra work, and that's a serious problem with this concept and the proof of concept exercise that we were doing. Now that's being addressed by trying to make it something that everyone does in common. So if we have something like ICD-10, and we're all doing that all over the world, all over the country, or ICD-9 for that matter, then we can use, then that's going to help us to not have hundreds of different ways of saying right breast cancer, because there's a code for that. And the code is a single number that represents that thing. It may be wrong, but at least we're using the same words to describe the same thing across the board. Well, it turns out ICD-10 is scheduled for implementation next year. And as you may be aware, very recently, also within the last couple weeks, they caved and said they would no longer require that deadline. So this was going to cost, you know, from $100,000 to $3 million, just a ton of money to different practices depending on the size. And so the AMA threw a fit. I was there. I get to participate in the AMA. I actually have to take this moment to give a plug for those physicians in the audience who are not members of the American Medical Association. Maybe we all are. Is that part of our mandatory? I don't know. But it really is a useful thing to be involved in, and they do advocate for us. And we passed a resolution back in November when I was at the meeting that we wanted to lobby against ICD-10 implementation immediately until we could further prepare ourselves for that and accommodate some of the concerns that physicians had. And that carried the day. It actually happened. Kathleen Sebelius, the HHS secretary, responded and delayed the deadline, and we were successful in doing that. Now, the flip side is everyone else in the world, all other developing countries, as it was described to me, or developed countries, are using ICD-10. So now we're the ones who are polluting the data with incompatible information. But it's not a trivial thing to switch over, and this is the type of thing that we're going to see over and over as we move forward. So how do we make it work? How do we get those benefits better? This is one way, by having standards, by having open communication, by having constant improvement and iterations, by iterating to have things work more appropriately. We have to recognize the problems. Let's not be naive about how these things are going to go, about the benefits. I think that people recognize that the intent is for improved care, decreased costs and these sort of things, but it's not that simple. All of those things have caveats. I also thought this was an interesting quote. The problem of having too much information has now surpassed that of having too little. It will become increasingly difficult to review all the patient information that is electronically available. Part of the problem with that is these automatically populated notes that we have, where you can copy and paste from previous notes, and you can import problem lists, medication lists, all this sort of thing. And you feel good about yourself because, geez, you know, I saw this patient for an hour and doggone it, it should have 10 pages of documentation because that will represent the effort that I put into this. But we all know as physicians that you get that consult note from someone else and it's infuriating. I just want the 3 sentences that tell me what you're going to do with the patient. I can't find it anywhere. All I can find is 10 pages of medications and all sorts of superfluous information that I already know. I already have that information elsewhere. And so it's kind of a big issue, and it's something that we struggle with. So from the physician side of things, the time required to do this structured documentation is huge. And I think we all know that and recognize that. And if you don't, then you're not doing it right. If you're just dictating it, then you're missing out on the opportunity. From the other side of the things, the record itself, the software itself is not perfect. And I think that sometimes we overestimate the degree to which other people or the software vendor or whoever is responsible for making this a difficult situation, and underestimate our own responsibility to educate ourselves and to spend more time to do a higher quality process for our patients and for healthcare. So we need to invest ourselves, recognize that it's something that's here and that we're going to serve ourselves well by investing the time now to really get ourselves comfortable with these tools and learn how to use them effectively. I can't tell you, I have several slides where this is supposed to come up, but how important it is to recognize how to use the tools that we have. If there's one thing I've seen over and over and over again, I'm a little bit of a technology nerd. Before I went to medical school, I worked in technology. I worked with technical support and that sort of thing. And it was always interesting to me when I showed people how to do a keyboard shortcut for copy and paste instead of right-clicking with the mouse or clicking the little buttons there. How many hours of their lives would have been saved if they knew that 10 years earlier, because of how frequently we use that function. And that's just one little thing. But understanding the features and the way to do things right inside a tool makes all the difference in efficiency. Oh, and actually, let me go back here. My last bullet point, don't be insecure in the process. And this is a little bit of a vague way to just point out that I've seen some physicians who feel a little bit insecure when they're afraid that somehow the electronic medical record is going to supersede their role, or that cookbook medicine or this, that, especially at the AMA. When I go there, I get the sense that physicians are always in this constant state of just under the surface there's a little bit of fear that they feel a little bit insecure about scope of practice issues or this, that, or the other thing. And the fact is, these tools will greatly assist us and help us to be more effective physicians, and so let's not be insecure. This is a quote from emails that I've been exchanging on this, and it's important to recognize that most of the issues that we see stem from user error. If you're not able to use the record correctly, it's probably because you're not using it right. And for me, I have support for application systems on my speed dial. I mean, I call them regularly, probably at least once a week, maybe more often than that, sometimes several times in a day. And I'm going to get to that in a minute in terms of the resources that we have here. But I just need to finish up because we're out of time. Everyone's leaving. So ultimately, we want to avoid sloppiness. This is what I talked about before, about copying medical records, copying and pasting things. You may bill for things twice when you do that. And certainly, even if it's not deliberate fraud, this is not going to be viewed favorably by payers and by the government when they do audits of our records. And just this last week, I've seen records that have a woman's physical exam that talk about the GU exam, and very affirmatively and reassuringly tell you there's no abnormalities to the penis and scrotum and genitals, and it's a woman's record there. And other places like that where it's clear that there's been sloppiness, and some of these functions of copying and inserting data automatically have been, and I'm guilty too, so not of that. I don't know of any time, but we all need to be vigilant on that. So this is kind of a gripe sheet for some of the things in Epic that I find a little bit frustrating, that I think are engineering issues that are outside the control of the physician, but I'm not going to go into those details. Redundancy, we have a radiation oncology product that conflicts with our Epic product, and I imagine many of the departments in the hospital have their own products, and that leads to possible errors and redundancy of information. Now, it's important to know what resources we have. I would just like to give a shout out to the folks who have been extraordinarily patient with me as I've been learning to use the EMR here. And I would say we have very first-rate support here in terms of being able to use these things. Here's an email in which I met with Amber Deerdoff, who was able to sit down with me and reassure me and show me how to do some things, and then follow up later with extensive instructions and screen captures and detailed information that was extraordinarily helpful, and now I have as a resource that I can look back on. There's still room to improve on these things. As I mentioned, I didn't know till yesterday we can import Epic records from UIHC, even though I would love to have known that, since I've gotten plenty of fax records from UIHC that had to be re-entered. And then Sharpening the Saw, shout out to Stephen Covey. I don't know if you're familiar with the 7 Habits of Highly Effective People, but this is just back to what I was saying about knowing your tools. You will be paid off for the investment that you put into learning how to appropriately use your tools. And so, in conclusion, that's our goal. That's what we need to do individually and as an institution, is to learn how to use what we have and hopefully also provide feedback so that the Army of Engineers, the government policy wonks who are guiding the incentives, so that we can get all of these features of the electronic medical record to benefit our patients. So where are we headed? We're going to get there. And if there's a couple questions, I don't know how much time we have, but I'm happy to discuss. Dr. Partridge.
I'm sure I could easily monopolize a microphone. If you're not busy the third week of September, come to the users group meeting. I think you'll find it great. At Epic, any of the physicians can come, and I can get you information on that. There's a variety of things that Epic's doing to address the topics you brought up. They'd like to develop a couple of different programs, one called Patients Like Mine, another one Patients Like Me, that allow you as a physician to group together your patients who have unusual diagnoses with everybody else around the world, and the 31% of Americans who are cared for through Epic. Patients Like Me would allow patients with weird diseases to group together. I don't know if you've ever been involved with automobile racing, but if you go to your mechanic and you say, hey, how fast can you make this car? His question is, how much money do you want to spend? That's why Google's so great. They have billions of dollars. So it's really, how awesome do you want your EMR to be? How much money do you want to spend? Healthcare dollars constantly getting squeezed. You can only spend so much. $10 million was our local tolerance for investment. And, to argue that should have been more would have been hard. Errors happen. When you're talking about errors that occur, the great thing is almost every paper that's been written about EMRs causing errors, in fact, I'll say every one that I've looked at, that institution very shortly later switched to Epic. And that's been reported at the Epic users group meeting, and I've checked into it, and they're right. So I still think we're in the right product. Data mining is something Jody does all the time to find out which one of her patients is not showing up to their mammogram. So, right, Jody? She data mines all the time. Judy Faulkner is the originator of Epic, and she's one of the policy wonks also, because, and the only smart thing Obama did, he put her on the committee that decides interoperability between all these systems, so hopefully that can continue to be fixed. From my standpoint, all these things you brought up are things that keep me up at night, and I think about a lot too, so I love that you decided to talk about this. I think the old-fashioned medical record put all the pressure on the physician, because you had all the information, doc, you should have done the right thing. And the current take on it is that we should share that information with the patient, and we should share the responsibility, and maybe sometimes that keeps us out of trouble. And I think the future is that all that information is going to be shoved at the patient with all of the patient-friendly way of understanding things. And so that the pressure is primarily on them when things go wrong. Well, patient, you knew you were supposed to come in for your colonoscopy. You got all these reminders from the EMR. So I agree with you. The future is bright.
Okay, well, thank you for that comment, and I want to clarify and make sure that everyone understands that I certainly don't intend to criticize the fact that we have Epic. I'm very pleased with Epic and the great support that we have here, and that's the challenge in this talk, is making sure that I talk balanced about the challenges and the opportunities of this without being disparaging unfairly. And I recognize wholeheartedly that many of the limitations that I've discussed here may be due to the fact that I'm not fully educated about that. The brilliance of Google is not that they have billions of dollars so that they can spend on their engineering. It's that they earned billions of dollars by providing a quality product to begin with. They found a way to engineer this so that by delivering the information that you need, by delivering you a service that you want, they made money. So it was a win-win. And I submit that that's what's missing here. We shouldn't have to fund this research. It should be something that there's enormous potential for development and reward for those companies that come up with these solutions without us having to triple what we pay for it. I believe that. I believe that very sincerely. I commend to all of you to read that book about Google. It's fascinating, or the one about Steve Jobs for that matter. And it's incredible what kind of focus on insanely great products can do for a company. And I believe that part of the problem is that we're being driven by incentives that are well-intended but somewhat artificial. and that there's so much bureaucracy that stops the sharing of information and this type of thing that it makes it very difficult to innovate in a way that is as meaningful as it is with the iPhone in my pocket, for example. So that's opinion. You know, I don't have the data to back that up, but in terms of the opportunities and what we have for analysis, there's a lot of potential for improvement, and I see it coming, and I'm very optimistic about the future on that. So it wasn't exactly a question, it wasn't exactly an answer, but that's my response for you. Any other questions or thoughts?
Oh, okay.
All right, thank you very much.